Hi guys, welcome all of you. So today the YouTube session, that live session that we will be discussing is about the module 4 in medical gastroenterology, which included the topics of pancreas and biliary system. Okay, so I guess totally there are 25 questions and each of them would be try to answer, and wherever some updates are possible, I would try to, just add on to these topics. So today, the YouTube session, that live session that we will be discussing is about the module 4 in medical gastroenterology, which included the topics of pancreas and biliary. Okay, sorry for that. So I've also switched on my phone to just see if there are any questions that comes on the way. So we will start the session right away. So the first question that was asked was, a 35-year-old presented with oily stool since 3 months. On evaluation, the ultrasound abdomen was suggestive of chronic pancreatitis. What is the minimum dose of lipase that is necessary to prevent steatorrhea? Now, this is a question which similar question has been asked before. The options are A, 10,000 USP, B, 30,000 USP, C, 60,000 USP, and D, 90,000 USP. Now, what we should know first is what is USP? USP is US Pharmacopoeia units. And what is the other unit that we are well versed with? What we are also well versed with is the international units. So there are a few things that you have to know. The basics is, now suppose this is the normal pancreas. Now, if you divide the entire pancreas into, say, 10 parts, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You need at least 10% of the liver functioning to, kind of prevent steatorrhea. In other words, if you divide the entire liver, the entire pancreas into 10 parts, that 1/10 of minimum that is secreted is necessary to prevent steatorrhea. Now, what has been told is 10% of the liver secretes approximately 90,000 USP of lipase per meal. Lipase per meal. Okay, so this would be the minimum that is needed to prevent steatorrhea in a patient with chronic pancreatitis. Now, in clinical practice, we have a slightly different unit, what's called as international units that is used. What you should know is 1 international unit is equal to 3 USP. Okay, so this 90,000 USP will correspond to 30,000 international units of lipase per meal that will be needed to prevent steatorrhea. Okay, so this is important and a question that can be expected. So what you have to know is the interchange of units and the basic concept that what in normal health 10% of pancreas is able to secrete. So that's about it. So the answer for this question is D, 90,000 USP. In the question next time, they may ask a slightly different units. So what in clinical practice also we start off is for a patient with steatorrhea, we would start off with a dose of approximately, say, 25 to 30,000 international units of lipase per meal. Okay, so that same has been explained in Schlesinger and Addison, both of them, where the 90% concept has been discussed. The units of international units is equal to 3 US pharmacopoeia units is been told. What is commercially available normal ranges has been discussed. And then what you generally give as a starting dose from 25 to 50,000 international units per lipase is also has been discussed. So you guys can go through in depth about these particular topics later. But the concept of what is the minimum dose that is needed to prevent steatorrhea, I hope you guys have got it. Okay. So the next question is, Here is a 38-year-old man with history of chronic pancreatitis, complicated by a pseudocyst in the past, presents with history of hematemesis the evening before. You do an endoscopy, and this is the figure that you have got. For most of the students who have gone through my previous videos would be well accustomed with how to recognize the pictures from an endoscopy. Now, this is a picture where you are able to see one part of the scope. So the scope has got retroflex when you're seeing at the fundus of the stomach, and you see some grape-like projection here. So we have no doubt what we are seeing. What we are seeing is actually called as gastric varix. Okay, so we are seeing a patient with chronic pancreatitis who have got gastric varix. So the question is simple. They have just asked what is being seen. So the answer is clear. It is B, gastric varix. So it's quite simple. Okay. Now, what you should know is, as students, the causes of varices is not only chronic liver disease with cirrhosis, portal hypertension of any form like splenic vein thrombosis, which can be a complication of chronic pancreatitis, is also one of the complications of, complications where you can see varices in the stomach. Okay. So these are few of the topics that are tested upon regularly in your examination. So the next question I would want to discuss is, which among the following are included as a component of standard MST endoscopic ultrasonographic criteria for chronic pancreatitis, except the A, stone, B, cyst, C, main duct stricture, D is hyperechoic main duct margins. What's really important in this question is classification. Always know that chronic pancreatitis can be diagnosed by ultrasound, it can be diagnosed by CT, it can be diagnosed by ERCP, it can be also diagnosed by EUS. Classification wise, there are various classifications for each of the modality. What you should know, ERCP is of late not used for the reason of diagnosis. It's more of a therapeutic test. In EUS testing, there is one classification called as MST criteria, and there is one more classification called as Rosemont's criteria to classify the type of chronic pancreatitis by different scores. Now, this has been asked as a question because the answer to this is present in the Harrison, the recent edition. So what they say is they divide the entire criteria into ductal and parenchymal. Now, stricture is never a part of chronic pancreatitis diagnosis. Okay. You might get stricturing ducts, especially in autoimmune pancreatitis, but it's not the part of diagnosis of a chronic pancreatitis. So what are the different features that are included in MST criteria are ductal and parenchymal. Now, ductal, remember a simple diagram with a small progression. One, you have a stone within the duct. Next part of the diagnosis is a thick wall, enhancing wall, then an irregular duct, okay, then presence of a dilated duct, and then visible side branches are all features of the ductal component. So I've included most of it. Yes, all of them covered. In the same way, even parenchymal, you have some criteria like first is echogenic strands, echogenic foci, then some lobularity, and then cysts. Okay, so these are the four, the components, the variables in the criteria that are there. So these are simple ways to just remember them. So you can use these simple ways to remember the different, variables inside the criteria. The other classification, if you're having time, can go through is Rosemont's classification. You can go through page number 935 in Schlesinger. Okay. Next question is, it's about elastase. What they say is a 45-year-old with chronic pancreatitis presents with oily stools. You order fecal elastase. Which among the following is true about the same except? Now, which among the following is true except? Now, always remember except is an important part while you answer the question. So let's go through the options. A is fecal elastase 1 levels more than 200 microgram per gram is normal. We have discussed this time again and again. So this is true. Second is false positive results if stools are not formed and hence should not be done in patients with diarrhea. Now, in patients with diarrhea, the stool is kind of diluted, so the elastase will be lower. So it is kind of a false positive test. So this size seems true. C, false negative results have been observed in patients with diabetes and irritable bowel syndrome. Okay, say you don't know how to assess this option. Let's go to the last option. Levels less than 100 is considered severe exocrine pancreatic insufficiency. Now, we know this is true because more than 200 is normal, less than 200 is abnormal. 100 to 200 is moderate pancreatic exocrine insufficiency, shortly called as PEI. Less than 100 is considered severe pancreatic exocrine insufficiency. So the odd one out is C. But however, remember, in many of our clinical practice, patients with diabetes, sometimes when you go ahead with doing an elastase, they have a false positive result, that is a lower elastase levels. So this is wrong because it causes false positive results and not false negative results. Okay, I hope you guys understood. So the facts about this is also mentioned in Harrison 2654, page number 21st edition, where they discuss a little about this. What is positive result is a decreased fecal elastase, which can also occur obviously in chronic pancreatitis and cystic fibrosis. False positive can occur in few conditions like diarrhea, diabetes, and irritable bowel syndrome. Now, these three false positive results have to be important. So if a patient presents with diarrhea and you're suspecting steatorrhea, please do not order a test like the fecal elastase. It's invariably going to be low. Okay, so that's a clinical point that we'll have to take from here. The next question is, which among the following is true about direct secretin stimulation test for detection of early chronic pancreatitis, except? Now, again, this is an except question. You know that there are very few tests to detect chronic pancreatitis at an early stage. One of the most important ones are these direct stimulation tests. The most important one among it is secretin test. So among the options, what I would like to tell us, the first option is secretin is given IV the dose of 0.2 microgram per kg as synthetic human secretin as bolus, which is true. Normal volume output is more than 2 ml per kg per hour. You might not know. Next, normally bicarbonate output is more than 10 millimoles per liter in 1 hour. D is normal maximal bicarbonate secretion is less than 80. Always, sometimes, many times, it's common sense which tells an answer for this question also. Even if you don't know the numbers, you know that the maximum, when they tell you maximum is this, it cannot be lower than something. In normal pancreas, it is usually up to some level. So among the options, what looks most probably the obvious one is D, with respect to telling that maximum level is up to 80. But if you have to go through the facts, please know this: the direct secretin stimulation test is an important test to detect early pancreatitis. The functional capacity of pancreas is reduced at a much early stage. So what is basically done, again, this is from Harrison, it's mentioned clearly in this particular page number 2656. What they say is about the dose has been mentioned, 0.2 microgram per kg of synthetic human secretin given as bolus. Now, what is normal values? The normal values are, first one, remember the volume. Now, the volume is more than 2 ml per kg per hour. Second, what is the bicarbonate secretion concentration? It's most of the time the concentration is more than 80 millimoles per liter. And the third thing is the output per hour is expected to be more than 10 millimoles per liter. So these are some of the numbers that you might have to know. The most reproducible, it is quite a good test. It's the repeatability and is possible. And the cutoff of less than 80 is considered abnormal and is suggestive of reduced secretory function that is most commonly observed in early chronic pancreatitis. So less than 80 millimoles per liter concentration of bicarbonate. Okay, the concentration of bicarbonate less than 80 is the key word that you should look for while you are assessing a patient with early chronic pancreatitis. And this question is asked. Okay. So the next question is, all are components of modified Marshall score for detection of organ failure in acute pancreatitis. Again, an except question. Modified Marshall score is used or to detect the organ failures in an acute pancreatitis. Now, the different components are cardiovascular, pulmonary, renal. Now, impaired mental status is not a part of modified Marshall. This one actually comes in some other score, what we call, there are different scores, like BISAP is one of it, where you can have impaired mental status as one of it. So, modified Marshall score, one or more if present, is considered as having organ failure. And the most common inputs in this is the cardiovascular, which includes systolic BP and heart rate, pulmonary, which includes PaO2, and renal, which is measured by creatinine. So these are the 3 points. Now, what I want to tell you is, now this is an important question. So also know the other scores which tell there is severe pancreatitis. These are HAP score, BISAP, Apache more than or equal to 8, Ransom's, again 2 tests at admission and at 24 hours. So you have this as 2 at admission and at 24 hours of admission. Okay, so you can do Ransom's at different timings, Glasgow score and SOFA score. Now these are all the scores that are they have different cutoffs to detect pancreatitis and severe pancreatitis. And the Ransom score were used initial days. The questions were also being asked. Even now, a Ransom score is important. Ransom score at presentation, that is at admission, and at 48 hours, at second day, both of them have been known to be, predict as severe acute pancreatitis. And there are various other scores which I've just mentioned. So please go through about them if you don't know about any of this. What they maximum may ask usually in your exams are, what are the components of each of them? And they may intermingle each and try to confuse you. So write down each of them and see what are the different components or variables in each. Okay, so that's important. So yeah, and Ransom's, again, there are multiple types. Questions has been asked in last 2 to 3 years consistently on this particular topic. Now, which among the following are features of type 1 autoimmune pancreatitis when compared with type 2? And it's an except question. Okay, it is more common in males, more common in elderly age, higher risk of relapse associated with inflammatory bowel disease. Now we are talking about type 1. Okay, so type 1 and type 2. Now we know, basic thing that we should know is type 1 is IgG4 mediated pancreatitis. Type 2 is not IgG4, it is something else. Okay, so when it is IgG4, remember, it is more in males, it's seen in elderly age group, and there are much chances of relapse. But these are more associated with various IgG4 phenomena and organ involvement, but not IBD. Type 2 is more in pediatric age group and is associated with IBD. So for this, you need to know about this particular table, mentioned both in different forms in Harrison and Schlesinger. And type 1, again, it's IgG4 is the key word that you should know. And other organ involvements are quite good. There are no other organ involvements, but what you should know is IBD is involved in type 2 AIP. Schlesinger, this is clearly mentioned, but this finding has not been mentioned in Harrison. So I've just added this point because it's not there in the book. Okay, so otherwise nothing much. So, and also IgG4 is the one which has a higher tendency to relapse. Okay, so these are the important points. And what they might test you is, recently there is a new entity called as type 3 autoimmune pancreatitis. Again, it can be tested and it's a recent add-on. This is a form of autoimmune pancreatitis that is triggered by immunity, which or the immune cells, which in turn is triggered by immune activators like ICI, that is immune checkpoint inhibitor pancreatic injury. So immune checkpoint inhibitor related pancreatic injury is called as type 3 autoimmune pancreatitis, a tentative question and uh, a question that you might expect in the next upcoming exams. Okay, so please read through about this new type 3 AIP. Keyword that you should know is immune checkpoint inhibitor related pancreatic insufficiency, which can present as asymptomatic lipase elevation or a symptomatic pancreatitis. So the treatment for this has been thought to be, steroids. So still research is on. Okay. What is important is when a patient, usually we stop the drug which causes pancreatitis, but the role of stopping this drug is questionable because most of the time these are patients who have cancer and there is a risk of progression of the underlying cancer. So, yeah. So the next question is, which among the following is true about pancreaticogenic diabetes except? Again, an except question. Now, pancreatogenic diabetes has some specific speciality about it. Okay. Now, if we know that this topic would be easy, ketosis is rare. Okay, ketosis is rare. Maybe, may not be. We don't know. Okay. Now, frequent treatment-induced hypoglycemia is seen. This is also called sometimes brittle diabetes. We know this is there. There is low level of insulin and counter-regulatory hormones. This is, we know both of the fact is true. When pancreas is, degenerated or atrophied, both alpha, beta, whatever type of cells should unanimously come down, and that happens. Now, microangiopathic complications are less common when compared with patients with type 1 diabetes with same illness of duration. Remember, hyperglycemia in any form for any fixed amount of time is going to similarly cause all the problems irrespective of the etiology. So this is wrong. Okay. So the best answer would be to go ahead with D. Okay. So D is the answer. Now let's see why. And let's know what are some special features. Now you know that in pancreatic diabetes, most of the hormones are less. Now, it is always better to know the pathogenesis. So I have just put up this small picture for you guys. In pancreatogenic diabetes, or what you call as type 3C diabetes, there is reduced pancreatic peptide. Now, reduced pancreatic polypeptide causes reduced hepatic sensitivity to insulin. So, when there is reduced sensitivity to insulin, that is from the hepatocyte perspective, insufficient insulin can lead to hyperglycemia. On the same way, when excessive insulin is given iatrogenically, two things are there which are contributing to the severe hypoglycemia that can occur. One, there is increased peripheral sensitivity to insulin because of the downregulation of increased insulin receptors that occurs. Okay. The insulin receptors are, increased because of the increased sensitivity to insulin that occurs in this population. And also remember the counter-regulatory hormones are also reduced. So the counter regulation that has to occur later is also less. Okay, so there's reduced gluconeogenesis, because of which these both can contribute to two factors. One, hyperglycemia, and the second is severe hypoglycemia, especially with treatment. So if you guys have to go through Schlesinger, page number 930 gives some of the points about type 3C diabetes. You have to remember that there is low level of insulin, there is low level of counter-regulatory hormones like glucagon and pancreatic polypeptides, there is rare ketosis and frequent treatment-induced hypoglycemia. About half of these patients would in turn require insulin in due course. And unlike type 1 diabetes, both the types beta and alpha cells are injured. Now, this combination has some specific features with respect to treatment. And remember that long duration can lead to microangiopathic complications, very much similar to type 1 diabetes. Okay. So these are all the special features about pancreatogenic diabetes. The next question is, which among the following is true about PSC except? Now, PSC is primary sclerosing cholangitis, again an except question. Small duct PSC is present in approximately 5% of patients with PSC. Now, this is true. Small duct PSC is where you have, the cholangiogram is normal. Okay, MRCP, what is usually done to diagnose PSC as imaging modality, becomes normal. Next question, next option is, around 5% of patients with PSC have ulcerative colitis. Remember, this is very important. PSC, if present, almost 50 to 80% of patients have the chance of having or harboring IBD. Whereas the other way around, it is around, if a patient has IBD, then the chances of him having PSC is up to, so 2 to 5%, we can consider it as 5%. So this option has to be read carefully, and now we know that it's wrong. Third is, MRI and MRCP has been used as imaging test of choice initially. Yes, it is true. Initial days, ERCP was used, but of late, because of its complications and easy availability of non-invasive modalities, now the MRCP is the test of choice of initial evaluation. Also remember the last option, gallbladder and cystic duct can also be involved in up to 15% of cases. We should know that this is true. Almost a significant number of patients, 15%, who have gallbladder and cystic duct involvement. Okay, so this is again detailedly given in Harrison. The numbers that you have to remember is around 50% of patients with PSC have ulcerative colitis, and small duct PSC is defined as histology that is consistent, but cholangiogram is normal, is in around 5% of patients, and it has a better prognosis. Now, these are the points where it is tested. Now, let's see a few extra points with respect to this particular topic. Now, I have already explained, if a patient has IBD, predominantly with colonic, ascending colonic involvement, which may happen in Crohn's or can also happen in right-sided UC, these patients have a significant proportion, around, you can remember, 5%, who have PSC. And if a patient has PSC, we should know that almost 50 to 80% will have IBD. So appropriate evaluation has to be done. And remember that PSC that is associated with IBD has some special features with respect to the IBD cases that you see. So what are these few special features that we should know about? Now, the Crohn's disease that is associated with PSC is generally less stricturing or fistulizing in its phenotype. Second, the inflammatory phenotype is predominant in colon. Okay, two important points with respect to Crohn's disease. With respect to ulcerative colitis, there is rectal sparing, there is backwash ileitis, and there is extensive colitis, especially of the ascending colon. Now, these are the specific features of UC that is associated with PSC. Many times they may not have very aggressive colonoscopic findings. So most of the time there can be just subclinical inflammation. But what we should remember is PSC, those associated with IBD or IBD that is more associated with PSC, are susceptible for increased risk of colorectal cancer, cholangiocarcinomas, and GB cancers. Now, this is important, and hence monitoring these patients at least annually for these malignancies plays a very major role. Okay, yeah. So next point, what I felt important is for you guys to just know the different types. They may ask you what's the most common form of PSC, classic PSC, where both intrahepatic and extrahepatic involvement is there. What is the least common is actually isolated extrahepatic PSC with only 2%. And small duct PSC has a very good prognosis, and it is approximately 5%. Now, these are the numbers that may be tested with respect to primary sclerosing cholangitis. Okay. Next is, A 35-year-old lady who is obese and diabetic presents with biliary colic. Her ultrasound shows cholelithiasis with dilated CBD. MRCP shows choledocholithiasis. Which among the following is true about choledocholithiasis? So they're asking what is true. So there's no except and this and that to confuse you. Just read them carefully. A. Passage of gallstones into CPD occurs in 10 to 15% of patients with cholelithiasis, which is true. Up to 25% of elderly patients may have calculi in the CPD at the time of cholecystectomy. As we age, the chances of having choledocholithiasis becomes higher, and many times they're also asymptomatic. Third, undetected duct stones are left behind in a small percentage of patients at cholecystectomy, and that is around 1 to 5%, which again is true. MDR3 gene defect leads to impaired biliary phospholipid secretion, may predispose to secondary biliary stones. Is false. It predisposes to primary biliary stones, because the difference between primary and secondary CBD stones, remember, students get confused what is primary CBD stone. Primary CBD stones are those stones which are primarily formed in the CBD without any contribution from the gallbladder. And secondary stones are those stones which are in the CBD as a result of falling from the gallbladder. So most of them are cholesterol stones in secondary stones. Okay. So you have to remember that primary CBD stones or biliary stones have been usually formed because of some inflammation or some predisposing feature within the bile duct. Okay. So these are the points that we should know about the difference between primary and secondary choledocholithiasis. So these are again Harrison-based question. You guys can read through page number 2650 for detailed evaluation. So again, what they say is that primary calculi arising de novo in the ducts are usually brown pigment stone developing in patients with parasitism or recurrent cholangitis or some congenital abnormality or dilated strictured ducts or MDR3 gene defect leading to impaired biliary phospholipid secretion. So these 4 points are really important. Many times you will see patients with choledocholithiasis, literally no stones in the gallbladder. Now, that happens in some situations, and that time you might have to think about primary calculi, and these are the evaluations that you generally look at. Next. Which among the following is true about choledochal cyst? Again, a common question, and it's an accept question. So let's go through carefully. Only 1/3 of patients have classic triad of abdomen pain, jaundice, and abdomen mass. May be true. It is predominantly seen in younger population. About 50% of patients present with onset of symptoms after age 10. Yes, majority of them are in younger age. Surgical treatment involves excision of the cyst and biliary enteric anastomosis. This is true, we know, because this has a predisposition to become cholangiocarcinoma. Oh, the last option is wrong because it's told us it's not associated with cholangiocarcinoma. The right answer is D. That is the reason you guys should know that choledochal cyst is treated aggressively by surgery and bilioenteric anastomosis. If it was not associated with cholangiocarcinoma, then you would probably do just excision of just the cyst, or you might not even do anything if the patient is asymptomatic. No, that's not the usual answer because it is associated with cholangiocarcinoma. It is a pre-malignant condition. You treat them aggressively. So the answer has been given here. What you should know is 50% of the patients do present with symptoms around this age group of 10 years, plus or minus, and rest of the options are all true. Now, what question could be asked in choledochal cyst that you guys should also know is be well versed with Todani's classification. Now, Todani's classification is important with respect to it's a very important topic when it comes to the types of choledochal cyst that you get. Type 1, there are totally 5 types, and also remember the 5th type is one which is also called as Caroli's disease. Okay, yeah, that's about it. Now, let's go for the next question. Yeah. A 45-year-old has presented with watery diarrhea since 6 months. Her daily stool is 7 times per day. Only significant past history is that she's undergone cholecystectomy 8 months ago. She doesn't have fever, weight loss, or any other alarms. You diagnose her probably that she's having post-cholecystectomy diarrhea. What is true about this condition except has been asked. Now, the bile acid composition in the colon is more diurogenic secondary bile acid, deoxycholic acid, which is true. Cholecystectomy shortens the gut transit time by accelerating fecal load through the colon with marked acceleration of the left colon, which may be right, but I'll tell you why should left colon get activated, because the gallbladder is present on the right side, and removing that should probably, trigger the right side. So just hypothesis. C is this occurs in 5 to 10% of patients undergoing cholecystectomy, which is well said. We should be counseling patients undergoing cholecystectomy about this particular complication. Usually they'll ask whether cholecystectomy, if my gallbladder is removed, is it safe? It's always prudent for us to tell about intra of anesthesia complications and lead complications like this, which can occur, which is around 5 to 10%. Treatment usually involves giving cholestyramine for effective amelioration of the area. So this is true. So what's the wrong answer is probably B. It should probably increase the colonic transit time, probably by stimulating the right side of the colon. And well said, in the Harrison 2649, you would get details about how this question has been set. And if you go through them, this would be an easy question. Next question is a general question. Which among the following is not an oncogen? It's not an oncogen, though you should know that as a gastroenterologist, APC, okay, as gastro attending student, APC is a tumor suppressor gene, okay? So if you know that, then you can answer this. Or there are a lot of mnemonics which you guys can go up. One of it commonly I used to use before was oncogene, where the example of my rash sister wants to talk about her, where you can have different mnemonics which comforts you guys. Mic, RAS, Cis, WNT, adenine, TGF alpha, ABL, HER, and ERB are all oncogenes. Always conceptually, it was very difficult for me to remember them exactly. So the mnemonics were the one which helped, and it is still helping many students because this question is quite common. I have a simple analogy which I got from the internet for students who have some difficulty to understand about them. What you have to understand is proto-oncogene works in one direction and tumor suppressor genes work in the other direction, ultimately maintaining some homeostasis. When there is overspeeding with respect to an excessive oncogene activation, then you have cancer. Or when you have suppression of the tumor suppressor gene of both the alleles. So I would probably try to put two parachutes here, and if they get suppressed, again tumor suppressor genes get inactivated. That is a condition of no brakes, which can again lead to cancer. So you can have it when there is too much proto-oncogene, like too much fuel in the vehicle and getting into a rash thing, or it can be a tumor suppressor gene which are inactivated, and when both the alleles are inactivated can lead on to cancer. However, what you should know is just one mutation of oncogene is enough, whereas you need both the alleles for the tumor suppressor gene to be affected. Okay, and because of this, there are some gross differences between both. The tumor suppressor gene related malignancies are more organ specific that you can get, and usually they have associated germline mutations where one is germline and the other becomes somatic, and when both the alleles are affected, you can get this kind of picture. Okay, so this is just for simple explanation. Please go through different mnemonics that you can. Next is the question: Which among the following germline mutations are associated with least incidence of pancreatic cancer? Is it BRCA1, PALB2, BRCA2, and STK11? For this, you kindly go through this table. The answer is actually BRCA1. What you should know is BRCA1 is not the one which is, though associated, known to be associated with pancreatic malignancy, it's not as much as the one which can result in a BRCA. So BRCA1, yes, but among the options given, it is BRCA2, which is more associated with pancreatic malignancy and not this. Okay. Now, I see a question which says APC can result into familial adenomatous polyposis syndrome or Turcotte. So, yeah. So, what I would say is, yes, it can. Now, APC itself has, it's not a single gene. It's a line, and there are different spots which can get affected and lead to different manifestations or phenotype. Specific location, suppose in the promoter region or the tail region or the main region, can lead to different specific types of phenotypes, where some of them may have a condition called a CHRPE, some of them present little differently. So it's not like APC gene is a single line. There are multiple types, okay? So different regions can get affected, resulting in some variations in the phenotype. So it's not a one-on-one phenomenon, okay? Now, 15th the question is, which among the following are special stains for hepatocellular carcinoma, except, again, a question previously tested in exams. It's not a direct repeat. There are some modification that's done. It's an except question. GPC 3, glutamine synthetase, heat shock protein 70 are all special stains used for HCC, and CD34 can help in diagnosing, but then it is more specific for a neovascularization that occurs in malignancy. Okay, so for that you have a combined answer from Harrison and Schlesinger. You can go through the respective page numbers, and special stains, positive staining of 2 or 4 of these markers, glypican 3, glutamine synthesis, HSP70, and clathrin heavy chain are highly specific for HCC, and gene expression blueprints, which includes glypican 3, Li1, and survivin, are able to distinguish between high-grade dysplastic nodules from early HCC. Also know that progenitor cell features like K19 and EPCAM or neovascularization, that is CD34, can help in additional staining and telling some of the features. Okay, so let's go to the next question. 16th question. Atezolizumab bevacizumab combination has recently become the new first-line systemic therapy for advanced hepatocellular carcinoma. It is as a result of which landmark trial? See, sometimes trial questions do occur in gastroenterology, and this is one of the few topics where trials can be asked. And what you should know is, because it's a first-line drug, obviously, I Am Brave 150 trial is the one on basis of which you have this new first-line therapy. Apart from this, the next in line are sorafenib and denvatinib, respectively. You have the SHARP trial, REFLECT trial, and for regorafenib, you have RESOURCE trial, cabazantinib, you have Celestial trial, and ramucirumab, you have the REACH2 trial. You can just write down this and try to revise them in your free time. They're definitely important. But what the recent change after your elite that I have to tell you is, new add-on has been done to the first-line medication. So now this is the recent BCLC criteria. Now the recent BCLC criteria has many add-ons. Now these add-ons are many, and they have subcategorized some of them. So what I would want to tell you is, in the recent BCLC criteria, go through it specifically. Here in the first line for advanced malignancy, you have 2 options, atezolizumab, which I have told you, and durvalumab and tremelimumab as the combination which is considered as the first line. So now this addition has happened in the recent BCLC criteria, and this is based on a trial, which can be your next question. That is the Himalaya trial, where this is the first phase 3 randomized open label trial which tested on use of tremelimumab single dose followed by intervals of durvalumab compared with durvalumab and sorafenib, and this particular combination was equivalent, if not inferior, to the existing first lines. Okay, so this may be a tentative question for your next exams. Next question is, a 50-year-old male with a history of diabetes mellitus presents with jaundice and fever. He underwent laparoscopic cholecystectomy 1 year ago for symptomatic cholelithiasis. On examination, the blood pressure is borderline. You suggest admission, you give IV fluids, antibiotics. After the blood culture, she seemed to be a little disoriented. Ultrasound screen shows IHBR, distal CBD could not be visualized. You do blood tests and WBC is elevated, and there is deranged LFT, liver function test. Her blood pressure improves after adequate resuscitation. Next, what is the best step? Is it EUS, or is it MRCP, or is it ERCP or PTPD? Suppose the patient didn't recover from the low BP, patient is too sick for doing an emergency ERCP, PTPD would have been the best answer. But here the patient got better, so ERCP will be the best answer. But why ERCP here? Till now we have not got a diagnosis of choledocholithiasis. Why to do ERCP? Now remember that the pretest probability of choledocholithiasis with cholangitis is very high in this case because of the presentation. Now look at the presentation. Patient has abdomen pain, fever, jaundice. Already the Charcot's triad is there, which is quite rare to see. On top of it, there is some disorientation, so it's going towards a pentad. So Raynaud's pentad is one of the most important indication for urgent ERCP clinically, but not all the time. Especially in elderly patients, you might have very subtle features. You might have just cholestasis. You might have some diffuse malaise, these aspecific, non-specific symptoms. So apart from these two, also know the Tokyo guidelines, which helps you in diagnosing a patient with cholangitis and then grading him into different types and then triaging the patient for EUS. So what I would want you guys to know is the Tokyo guidelines, Tokyo 2018 guidelines for acute cholangitis, which has three things you should know. One is inflammation, one is cholestasis, and imaging based data. Using these three with two subtypes for each, they diagnose the cholangitis. And again, you can classify the severity as 3, 2, and 1 based on organ failures. Especially organ failures means any one of it is also an indication of severe cholangitis. You guys can go through it in your free time. So these are tentative topics. Okay, so yeah. Next question is, which among the following parameters is not included in Tokyo criteria for cholecystitis? So remember, Tokyo's criteria is for cholangitis and cholecystitis. Now I have just specifically asked for acute cholecystitis. One is Murphy sign, right upper quadrant tenderness, fever, elevated procalcitonin is not a part of Tokyo's criteria. Now, Tokyo's criteria, you guys can go through again, very similar to cholangitis criteria, except that here there you have cholestasis. Here you don't have cholestasis. Okay, you don't have cholestasis as part of criteria. You may get cholestasis and jaundice, but they are not mentioned as a part of the criteria, unlike that of cholangitis. Okay, see, these are some differences you should know. So go through, take a screenshot of this particular picture and then the Tokyo guidelines that I just showed you, and then just compare for cholangitis and cholecystitis, what are the slight differences, and be ready with your concepts. Okay, yeah. So next is, This simple question again, gallstones are formed because of abnormal bile composition. Which among the following type of stones are formed secondary to chronic biliary infection? Is it cholesterol stones? No. Black stones? No. Brown stones? Yes. Mixed stones? Maybe. Okay. So what you should know is the different type of stones, and infection generally leads to a specific variety of calcium bilirubinate stones called as brown stones. Okay. Hemolysis more causes black stones. Next question is with respect to ultrasound of gallstones, which among the following is true except? Again, an except question. What we should be looking at is A, ultrasonography of gallbladder is accurate in identification of cholelithiasis, but is inferior to OCG, but is commonly used due to its ease of availability. Wrong. Ultrasound is best for gallbladder stones. Okay. It's so easy to see the gallbladder calculi on an ultrasound. So ultrasound becomes the best. So first option itself is wrong. So A is the best answer, but let's read the other options. Stones as small as 1.5 mm in diameter may be confidently identified provided that firm criteria are used, like acoustic shadowing of opacities that are within the gallbladder lumen and that change with patient's position by gravity. Now this is true. Ultrasound is very good. Just remember that. False negative, false positive rates are seen in ultrasound in gallstones, a very small number, approximately 2 to 4%. Biliary sludge is a low echogenic activity which forms a dependent position layering within the gallbladder. So this is a definition of sludge, which is again true. So the answer is A. You guys can go through Harrison page number 2645 if you want little more details. What you should know is ultrasound is very accurate. It has in fact replaced OCG, which was done before. It is good at even detecting as small as 1.5 mm stones. It can also detect sludge materials also. You can differentiate between polyp and stones. A lot of ways. So ultrasound is the best, but know that false positive and false negative both occur in minority of patients up to 4%. Okay. Now, this data again is from this particular table where they talk a lot of things about the advantages, the limitations about the ultrasound, but you should know that it is the procedure of choice for detecting gallbladder stones. The next question is true about HIDA scan are all except. Now, HIDA is a radioisotope scan which tells the secretory ability of the biliary duct and the gallbladder functioning. Let's go through it. It is contraindicated in pregnancy, true, because it's radioactive. It is not useful if the bilirubin is too high. Again, true. Cholecystogram is a low resolution, definitely of late. It is not done well because the activity that is taken or the picture that you see is not of high resolution. And it is more sensitive and specific for chronic cholecystitis than acute cholecystitis is wrong. It is very, very, very specific for acute cholecystitis. In chronic, it is useless because the gallbladder contractility is affected. So these are the tables that you should know about HIDA scan or cholecystintigraphy. It is, of course, contraindicated in pregnancy when bilirubin is high, and you should know that one of its disadvantages, it has its low resolution. Always remember that it is the best test for confirmation of suspected acute cholecystitis. Okay, so yeah, this question is done. Let's go to the next question, which is the most common type of malignant cause for obstructive jaundice. Okay, in this question, you might have some controversies in with respect to the way you answer, but remember, most of the time they're talking about adults, mostly in middle and elderly age group. The most common type of malignancies presenting as jaundice is actually carcinoma of head of pancreas. Now, this almost debatable with that of gallbladder adenocarcinomas advanced, where it goes and blocks the duct or common bile duct in stage 3. So that becomes the next common cause. And this is much more seen in younger age group. And then comes cholangio and ampullary malignancy. So if you go through while evaluating a patient of obstructive jaundice, you should know that most of the time it is a malignant cause that causes jaundice if there is obstruction. And if it is a malignant cause, know that with the age group, you can again differentiate Early age group, you will think of an anomaly like choledochal cyst. Middle age group, you may be thinking of a condition like gallbladder malignancy. And elderly age group, you may be thinking about head of pancreas malignancy. If you have some added features, you might think of some other factors, like if patient has intermittent jaundice with waxing and waning jaundice and waxing and waning cholangitis, you may think about ampullary adenocarcinoma or periampullary malignancies. So these are different ways of approaching a case. Patients may be asked in these directions. So yeah. So yeah, this is the answer, but then I think explanation is good enough for this particular question. Now, which is the most common cause of AIDS cholangiopathy? Now, AIDS cholangiopathy, as the name suggests, it is in advanced stages of HIV. The most common cause for AIDS cholangiopathy infective would be D, which is Cryptosporidium parvum. Now, this is a question that's been asked before, and you guys can go through. It's actually there is Schlesinger mentioned quite well. They have said that the most common cause is Cryptosporidium parvum. The next common cause is CFB. But however, the mechanism of how both of them result in this particular manifestation is very different. Okay, that I'll come up in due course. Then also remember the different changes that can happen in the cholangiogram or the bile duct is also important. It's also mentioned in the books. It presents like PSC, it can have papillary stenosis or a combination of both intrahepatic and extrahepatic, or it can have a significant extrahepatic involvement only. Okay, now this is a picture just to tell you just that Cryptosporidium parvum tries to activate the Fas receptor ligands and result in apoptotic bodies in the cholangiocytes, which in turn results in the stricturing disease. Second, also it causes some form of autonomic neuropathy from the bowel, which can translate into papillary stenosis that can present in these patients. The second most common cause, that is CMV virus, do not affect the cholangiocytes directly, but they actually affect the peribiliary arterioles and result in a very similar picture. So AIDS cholangiopathy, again, the other question that they may ask you is Sellos et al. Classification of different form of manifestation. It could be PSC-like feature, it could be completely papillary stenosis, or it can be a combination of both, or it can be extrahepatic involvement only, or it can also be sometimes acalculous cholecystitis. So various forms are there and there are different presentations. So you guys can go through the different ERCP methods. Especially it's more important for interview level, but at this point of time, know that most common cause for AIDS cholangiopathy is this, and treatment of choice is harder. Next is a pictorial representation of a hilar malignancy, and they've asked about bismuth classification. If you see the picture, you should know that till here it is 1, little more it is 2. If it occurs here, it is 3A. If it occurs along this direction, it is 3B. So the answer is D. Okay. So you guys can go through this. This is 1. When confluence is involved, it becomes 2. When any one of the sectoral ducts, that is secondary ducts, on the right side is involved, it is A. On the left side, it is B. Here, what there was is 3B. Okay, it's just about knowledge on bismuth classification. Go through them. The next question is, I think this is the last question. Yes, 25th question. A 45-year-old presents with history of biliary pain on and off since last month. Currently, she has presented with more constant pain. If the biliary pain persists beyond what time will you suspect acute cholecystitis? Again, a clinical question. Usually a biliary pain, you should always know that it is a simple condition where the stone blocks the cystic duct and gets back. This intermittent blocking is called biliary colic, and it can last up to 2 hours. But if the stone is impacted in the cystic duct or the neck, it can result in persistent pain, usually lasting more than 6 hours. And that's when you will think of acute cholecystitis, where the gallbladder becomes thick and big, distended, and severe pain, and sometimes also associated jaundice can occur. So the best answer is C, that is 6. Okay. Now, these are some of the explanations given on the standard books. You guys can go through these in your free time. But then acute cholecystitis is again an important topic. Just to tell you that almost 75% of these patients who present with acute cholecystitis would have had attacks of biliary pain. So that is the reason biliary pain once starts is an indication for cholecystectomy. Okay. If it's more than 6 hours, it's when you call a biliary colic into an acute cholecystitis. Okay. And acute cholecystitis is not just about the constant pain, it is also about other features of inflammation, which is severe, which is fever. But also know that fever generally do not cross 102 degrees Fahrenheit. And if it does, to think of further bigger complications like gangrenous uh, gallbladder or a perforated gallbladder. What you should also know is jaundice is present in significant number of patients, especially in older age group, and not all jaundice with gallbladder problem is choledocholithiasis. It can also be cholecystitis. In a clinical practice, as you see more and more patients, you start realizing this fact. Third, bilirubin is usually less than 4. When it is more than 4, you should also start thinking about an added diagnosis of CBD stones causing these problems. Okay. One of the other conditions which can cause a gallbladder stone with the jaundice is Mersey syndrome, which is where the stone goes and obstructs the common hepatic duct. Either there are different grades and also sometimes even associated with fistula formation. Now, natural history of cholecystitis is sometimes questioned, and please know them. If it's untreated acute cholecystitis, usually in a week's time, it resolves. Not uncommonly, it remits within 48 hours of hospitalization. On one of the studies, what they've shown is acute cholecystitis resolved without complications in almost 80% of patients. But what is scary is the complications. The gangrenous complication can occur in 7%, empyema approximately in similar number, or emphysematous cholecystitis in fewer than 1%. So these are the important complications that occur in approximately overall around 15% of patients. That is more scary, and hence surgery is suggested for these conditions before these things start occurring. Okay, so that's about it. I think we have discussed all the questions and the trending new topics. You guys can see that the time and the questions were framed, and by the time we are discussing today, there are so many new add-ons. A few of the new add-ons that I have discussed so far are type 3 autoimmune pancreatitis is one of the topic. Second, Himalaya trial is one new trial based on which you have one added type, first choice of HCC, unresectable HCC medications are available. Then we have discussed some new other add-ons based on different patients. Hope these discussions are helpful. Thank you. If you guys have any questions, please put up in the chat box, or we can discuss personally later in our discussion. And also, considering that your examinations are within next 2 months, I would like to like you guys to be more active in the WhatsApp group which we have. And for those of the few students who have not yet into our group, you please, you guys can WhatsApp me. My number is 74066484141. If you WhatsApp this particular number, then I would add on to a group of students, which has almost more than 300 students at this point of time, who contribute to questions sometimes when the discussion keeps going on. And as we go towards the exam, there are more discussions, more new updates, which keeps popping in. So thank you guys, welcome, and hope to see you guys again for other active sessions that will come up in due course. Thank you.